Thank you, sir, for an excellent talk and it's really informative. I think we will have the question answers after the second talk. So may I request, sir, we'll have this discussion after the second talk. Thank you very much. So we have our next esteemed speaker, Dr. Shreerang Godbole. He'll be discussing about how we should target diabesity in type 2 diabetes, which is a very hot topic, and one should be very focused while managing these patients in all subset and categories of patients which we come in our day-to-day practice. May I request, sir, to kindly take over. Thank you.
Thank you, chairpersons, friends. Good morning to all of you. And I shall be discussing a novel, probably a way of targeting diabesity in type 2 diabetes. We know that diabetes and obesity coexist more often than not in a large number of patients. And the reason why they coexist is because they're linked by various pathophysiological mechanisms, most of which are centered around insulin resistance and hyperinsulinemia. In fact, they're also causally related, so that for every kilogram rise in body weight, you could expect the risk of developing diabetes to rise by about 4.5%. Needless to say, this combination of diabetes and obesity imposes a significant risk on cardiovascular morbidity and mortality, and this is fairly common in our country, and that's the reason why we need to understand how to tackle both diabetes and obesity together when they coexist. Now, there are only two classes of anti-diabetic drugs which have unequivocally shown to cause weight loss in people with type 2 diabetes, namely the SGLT2 inhibitors and the GLP-1 receptor agonists. Now, of course, the route of administration by and large differs, though nowadays, of course, you do get oral GLP-1 receptor agonists. Coincidentally or otherwise, these are the two classes of drugs which have shown to have some benefits on cardiovascular and renal effects. The mechanism of action and the degree of benefit to the heart and the kidneys, of course, differ in these two classes of drugs. Both these classes of drugs share a common property. They do not cause hypoglycemia per se, and both of them, as you can see in the yellow, cause weight loss. But the mechanism of weight loss is different for GLP-1 receptor agonists and SGLT2 inhibitors. But what I want to emphasize is that even amongst the SGLT2 inhibitors, the mechanism of weight loss could be dose dependent. It really depends what dose of the SGLT2 inhibitor you are going to use. And if you use a higher dose of an SGLT2 inhibitor like Canagliflozin, if you would rather use 300 milligrams rather than 100 milligrams, you could potentially open up different mechanisms of action for weight loss. That's the point I'm going to drive today. So I'm going to discuss the use of 300 milligrams of Canagliflozin in diabesity. Now, one of the major mechanisms of weight loss with the SGLT2 inhibitors is caloric loss through glucosuria. That is, the renal threshold for glucose excretion is lowered with SGLT2 inhibitors. And speaking of Canagliflozin per se, we know that in normal individuals, the renal threshold for glucose excretion is variously described as between 180 to 200 milligrams per deciliter. And we know that in people with type 2 diabetes, the baseline RTG, that ranges, it's raised. So it's somewhere between 240 to 261 milligrams per deciliter. Now, Canagliflozin, or in fact any SGLT2 inhibitor for that matter, reduces the RTG in a dose-dependent manner. So speaking of Canagliflozin, the standard dose, which probably most of us use, is 100 milligrams. You find that by the time you reach a dose of 100 milligrams, you get a near maximal lowering of the RTG. But in fact, actually, if you compare with then 300 milligrams, in fact, from 200 milligrams onwards, the suppression is really maximal, and you could have a suppression of about 65% of the baseline RTG. And in fact, in doses in excess of 200 milligrams, that suppression not only is near maximal, but it lasts for really 24 hours. Whereas with 100 milligrams, there is a little waning of the effect in the overnight period, and therefore that effect is slightly lost. So certainly, as far as the RTG reduction is concerned, a 300 milligram dose is superior. So as you can read there on the right panel, Canagliflozin lowered the RTG in a dose-dependent manner with near maximal effect to almost lowers it to 90 milligrams, so you don't get hypoglycemia at doses in excess of 200 milligrams. Now, obviously, if you're going to excrete glucose in the urine, you would expect a lowering of the excursion in plasma glucose, as you see on the extreme left, and also in the serum insulin levels. Now, if you see three groups of individuals, you have placebo in green, you have a pooled group of Canagliflozin 100 milligrams and 200 milligrams in light blue, and then you have a pooled group in excess of 200 milligrams Canagliflozin, which of course includes 300 milligrams Canagliflozin in dark blue, and you look at the excursions of plasma glucose over time, okay, over how many hours. You find that especially in the first 2 hours, there is a very significant reduction in the plasma glucose excursion area under the curve with the pooled group using Canagliflozin in excess of 200 milligrams. And the same is true for the serum insulin excursions, especially in the first 2 hours. You would get a significantly better reduction in plasma glucose and insulin excursions in the group using 200 milligram and more versus 100 milligrams. Now, you might say that this is because of excess of glucose excretion with the 300 milligram dose versus the 100 milligram dose. Now, if you look at the right panel and you look at the actual urinary glucose excretion in the two groups. So, in the light blue column, you have 100 and 200 milligram pool group, which is actually, in the first 2 hours, it's 5.4 grams. If you look at the pool group using more than 200 milligrams, the urinary glucose excretion in the first 2 hours is 5.9 milligrams. So they're comparable, 5.4 versus 5.9. So it's not really the increased so-called urinary glucose excretion that is responsible for this benefit. And therefore, there are potentially other benefits, other mechanisms by which you get this benefit with a higher dose of Canagliflozin. Now, you know that SGLT2 inhibition, SGLT2 is responsible for about 80% of the reabsorption of the filtered glucose load, okay? So filtered glucose on a daily basis is 180 milligrams. 80% of that is about 145 milligrams. So if you were to use SGLT2 inhibitors and really inhibit this SGLT2 mediated reabsorption of the glucose that is filtered, you would expect actually 145 grams of glucose to be excreted in the urine if you were to use an SGLT2 inhibitor. But what happens? When you use an SGLT2 inhibitor, you do not get 145 grams in the urine of glucose. What you get is a mere 50 to 60 milligrams. Why does that happen? Why doesn't SGLT2 inhibitor block or excrete all that glucose that is being filtered, 145 milligrams? This is because when you start inhibiting SGLT2, at that time, in normal individuals, when SGLT2 is also functioning, the SGLT1 transporter in the renal tubules is functioning at a submaximal capacity. But when you now inhibit the SGLT2 inhibitors, co-transporters, the SGLT1 transporters now have to work at a maximal capacity, and their capacity is 120 grams. So finally, you end up excreting 180 minus 120, that's only 50 to 60 grams of glucose out of the 180 grams that was filtered. So if you were to use an SGLT2 inhibitor, which is highly selective only for SGLT2, compared with SGLT1, you have the inhibitory concentration 50, IC50 for SGLT2 versus that for SGLT1 with the various SGLT2 inhibitors. The prototype, of course, is fluorescein, which was given up because it is non-selective. It inhibits both SGLT2 and SGLT1, and therefore, as a result of unacceptable GI side effects, fluorescein had to be given up, and people started concentrating on a selective inhibition of SGLT2. So if you look at tofagliflozin, EMPA, Luzio, DAPA, they are highly selective for SGLT2 vis-a-vis SGLT1. But now, if you look at canagliflozin and the other molecule, which is actually sotagliflozin, sotagliflozin actually is a dual inhibitor of SGLT2 and SGLT1. You can see it's only just 20 times as selective for SGLT2 versus SGLT1, whereas Cana is around 150 to 250 times selective for SGLT2 versus SGLT1. On the other hand, if you look at the other SGLT2 inhibitors, they are in 1,000 times selective for SGLT2 versus SGLT1. I told you, if you only inhibit SGLT2, your SGLT1 will start functioning at a maximal capacity, and therefore that will now inhibit the glucoseuria. Now, if you also inhibit SGLT1 to some extent, not completely. If you were to do it completely like with fluorescein, you will end up with GI side effects. But if you were only to partially inhibit the SGLT1, you will get a more robust glucoseuria. And that is the reason why Canagliflozin has a greater glucoseuria compared to, say, empagliflozin or dapagliflozin. So with EMPA or DAPA standard doses, you would get an excretion, I told you, 50 to 60 grams of glucose per day. With Canagliflozin 300 milligrams, you get a glucose excretion of 75 to 100 grams per day, which translates to 300 to 400 calories per day. So you're losing more calories through the urine if you're going to use Canagliflozin 300 milligrams. So if you inhibit both, but just selectively the SGLT1, not too much, you would produce a robust glucoseuria. But remember, you can't inhibit SGLT1 too much. If you do that, you will end up, because SGLT1 primarily is in the gut. So if you inhibit the SGLT1 in the gut, you're going to get unacceptable adverse events similar to what you get with, say, the AGIs, the acarbose or the voglibose, okay? So you can't have too much of that. Too much of a good thing is bad. So you need to only transiently inhibit SGLT1 to avoid the acarbose-like GI side effects. And therefore, when you use Canagliflozin 300 milligrams, you get a better reduction of the postprandial glucose excursions because you are also inhibiting SGLT1. And that's the reason why other SGLT2 inhibitors, you can take them irrespective of your food. But Canagliflozin, you have to take it on an empty stomach, because within half an hour when it reaches the gut, the concentrations need to be high enough to at least transiently inhibit the SGLT1 in the gut. That's the reason why you need to use Canagliflozin on an empty stomach half an hour before the food, okay? So what I was trying to tell you is Canagliflozin is only 150-fold more potent inhibitor of SGLT2 compared to SGLT1, and the SGLT1 transporters in the small intestine are responsible for the absorption of glucose and galactose. And in fact, in phase 3 studies, a pre-meal administration of Cana 300 milligrams provided a greater reduction in the postprandial glucose excursion than was observed with a 100 milligram dose. I told you that inhibition has to be transient. You can't just keep on inhibiting the SGLT1. If you look in the right panel, this is the percentage of glucose that is absorbed after you have been administered oral glucose, okay? And the blue is the placebo, and the red is the Canagliflozin 300 milligrams. And if you look at the time frame, 0 to 1 hour in the first block, you see that Canagliflozin 300 milligrams inhibits 31% of the glucose absorption, 0 to 1 hours. If you now only consider 0 to 2 hours, the middle panel, you will find that the absorption has gone down. The inhibition of the absorption is only 20%. So in the first 2 hours, the inhibition is what there is. After that, from 2nd to the 6th hour, there is in fact a compensatory increase in the glucose absorption. So that now if you look at the extreme right column, that is 0 to 6 hours, you find at the end of 6 hours, the difference is just 6% between the two groups at the end of 6 hours of Canagliflozin administration. And therefore, what I'm trying to emphasize is that the inhibition of SGLT1 with Canagliflozin 300 is transient. It's only for 2 hours. So complete inhibition will produce severe GI side effects. It may limit the clinical utility. So a potent SGLT2 inhibitor that only partially inhibits SGLT1, such as Canagliflozin 300 milligrams, is free of GI side effects. And because there's a rapid absorption of Cana 300, the intestinal concentrations are only transiently sufficiently high to inhibit SGLT1. And therefore, in this particular study, no subjects reported symptoms of glucose malabsorption or GI side effects. So this is just the summary that SGLT1 inhibition by Cana 300 is local, it's transient, it's reversible, and you're not going to get GI side effects. Now, if you're going to inhibit the absorption of glucose in the gut, naturally, more amount of glucose nutrients will be diverted to the colon. And that is how the incretins are sort of stimulated. So if you inhibit the intestinal SGLT1, it improves the glucose homeostasis by inducing a sustained intestinal release of incretins. And one of the incretins, of course, is GLP-1. Now remember, this is an SGLT2 inhibitor. It's not a DPP-4 inhibitor. But still, Canagliflozin 300 milligrams, shown in black, if you see those dark diamonds, versus the triangles, which is the placebo, you find that the total GLP-1, mind you, with Canagliflozin 300 milligrams, is 35% higher compared to placebo in the first 2 hours. So you get an increase in GLP-1 when you use Canagliflozin 300 milligrams. So Canagliflozin being less selective, it elevates the level of circulating GLP-1, and that effect occurs by inhibition of intestinal SGLT1. In fact, if you combine the two, if you combine Cana 300 and you combine a DPP-4 inhibitor, you will get a further elevation of the active GLP-1. Now, GLP-1 is not the only incretin that is released. When you take food from the ileum and the colon, there are certain small peptides called peptide tyrosine, that's peptide YY, which is necessary for satiety. Now, in obese individuals, there's a deficient release of peptide YY, so that when obese people eat, they don't get easily satiated because the release of YY is less, and therefore obese individuals require approximately 225 calories more than normal weight individuals to reach a maximum satiety. So, in fact, if you inhibit SGLT1, it also not only increases GLP-1, but it also increases the release of peptide YY, and that assists in glycemic and appetite control. It's the same sort of group which I showed you with GLP-1. The same thing happens with peptide YY. You get an approximately 60% higher levels of peptide YY from 0 to 2 hours with Cana 300 compared to the placebo. Now, the significant weight reduction that you see with Cana, this is the trial which was done comparing Canagliflozin 100 and 300 versus glimepiride. I'm sure you are aware of this trial. And clearly you found that Cana 100 and 300 cause a decrease in the body weight, but 2/3 of that body weight loss is because of fat loss and not the lean mass. Okay, but if you look at the CT imaging studies further, it's actually the visceral adipose tissue which is reduced to a greater extent compared to the subcutaneous adipose tissue. Now you'll ask me, we are targeting diabesity, what about the HbA1c lowering? Now there are no head-to-head trials of SGLT2 inhibitors versus GLP-1 receptor agonists, so what we have to be content with is network analysis. You're comparing the effects across different studies, which could be fairly comparable. And if you look at the various maximum doses of SGLT2 inhibitor, so in this case Cana 300, versus maximum doses of a GLP-1 receptor agonist like liraglutide 1.8, you find that Cana 300 has superior A1C lowering compared to any maximal dose of any other SGLT2 inhibitor. Lira 1.8 has superior A1C control compared to Cana 300, okay? 1.2 has comparable A1C control. 1.8 has a superior control compared with Cana 300, but now if you take body weight lowering and do the same network analysis, in fact, the weight loss that you get with Canagliflozin 300 is equivalent to, or in fact even slightly better compared to even 1.8 milligrams of liraglutide in this particular network analysis. So as far as A1C reduction is concerned, both doses of liraglutide 1.2, 1.8 were statistically superior to all other doses of SGLT2 inhibitors, with the exception of lira 1.2 and Cana 300. Okay, they are similar. As far as weight reduction is concerned, liraglutide statistically comparable to all SGLT2 inhibitors, but 300 milligram Cana is statistically superior to liraglutide 1.2 milligrams in a network analysis. You will say, what about the safety? Is using 300 milligrams of Cana going to lead to major adverse events? You look at the global population studied, you look at the India-specific population study, by and large, they match. And by and large, probably, of course, the mycotic infections would be more common, and relatively speaking, volume depletion-related adverse events could be more common, relatively speaking, though absolutely, of course, the risk is similar. Adherence is important. The problem with GLP-1 receptor agonists, they're injectable, so adherence is a problem. That is not so with Canagliflozin. So we have various studies of adherence to treatment at the end of 1 month, 6 months, 12 months. The adherence with 300 milligrams Cana is superior, as expected, compared to the adherence to any SGLT2 inhibitor. So just my two concluding slides. With Cana 300, you get a near maximal reduction in the renal threshold for glucose for a full 24 hours dosing interval. There's a 25% greater 24 hours urinary glucose excretion and delayed and smaller PPG excursions. There's a greater reduction in the postprandial glucose insulin than could be explained by increase in the urinary glucose excretion. So treatment with Cana 300 delays intestinal glucose absorption during a mixed meal tolerance test. The intestinal concentrations of Cana 300 are high enough to transiently inhibit intestinal SGLT1, and that transient inhibition avoids the GI side effects. And the inhibition of SGLT1 stimulates the release of GI peptides like GLP-1 and peptide YY. The A1C lowering and weight loss with Cana 300 is comparable with GLP-1 receptor agonists with a better adherence, no more frequent side effects compared to Cana 100. I think I'll conclude my talk here. Thank you so much. It was a pleasure speaking with you. Thank you.